Next up, we have Dr. Dipu TS, who is currently an associate professor in AMRITA Institute of Medical Sciences. He is presently working in the infectious disease department, Department of General Medicine. He has over 27 publications, and he is the COVID nodal officer of AMRITA Hospitals. He is a leading infectious disease expert and is an international and national grantee from ICMR and BIRAC. And he has vast experiences in dealing with the COVID outbreak as well as post-COVID cases. I welcome you, sir.
So a very good afternoon to one and all. So today we will discuss about the long COVID, which is our next topic. So what is this long COVID? Who coined the name? So the name is coined by a scientist. The name is not coined by a scientist, but just by a normal individual called Elisa Perego. So why did she come up with the term long COVID? Because what happened is that the name got coined as early as May 2020. So during that time, after her COVID, the doctors has told that she has recovered from the COVID. When doctors tell that, during that time, when doctors tell that an individual is recovered from the COVID, what they mean is that they are clinically stable and virologically probably she would have RT-PCR or antigen negative, and then she is no more a public health threat, and the probability of she spreading the disease to anyone else is almost negligible. But what actually happens is that in spite of doctors telling that the patient is COVID free, during the subsequent period after the COVID, they will continue to have various amount of symptoms. So because of this lingering of the symptoms beyond the recovery, so as far as an individual is concerned, her or his COVID is kind of persisting, and hence she came up with this term called long COVID, and this started trending in Twitter. So that's how the background story of the terminology called long COVID, pretty interesting. And it is very important to recognize this condition because approximately 10 to 20% of COVID-19 patients experience this long COVID. So meanwhile, not only long COVID, in various other parts of the world, they came up with similar terminologies like post-COVID-19, post-acute COVID-19, long-haul COVID, or chronic COVID to address the same issue because of the lack of a universal definition. So all these try to address the same scenario which is happening, that is post-COVID, the people continue to have persistent symptoms. So I will just discuss few clinical scenarios. It is not a huge clinical scenario, it is just normal day-to-day scenario. One is my story. What happened to me when I developed COVID. So I had a pretty mild COVID. Of course, I had low-grade fever, cough, and headache, just like all of us had at some point of time. But then during my 7th day, I started having cough, and by 8th day, I developed a disc prolapse. So it is nothing much to do with COVID, but then still I got a complication of the COVID. Second scenario is the scenario of my colleague. My colleague is a very energetic person who is able to maintain the energy level throughout the day. So, but post COVID, she come with a lot of energy, but by afternoon her energy just drains out, and then the rest of the day she had to restrict herself to some kind of desk job. So that is the second scenario. And third scenario is one of our patient. So during one of my night duty, the patient came to our emergency room, and the person presented with fever. On examination, he had red eyes and diagnosed to have endophthalmitis. And as part of endophthalmitis workup, we did echo and found out that the patient had a vegetation. We did aspiration from the vitreous, and we have a very strong microbiology department which can grow anything from anywhere. And then they told that it is an aspergillus. So basically, it was an aspergillus fumigatus endocarditis with endophthalmitis. So this is the third scenario. So which of this is actually falling into long COVID? So let's examine this. So the last example which I have told, that is not really fitting into the classification of long COVID, but it is actually a complication of the COVID. So it is better to term as post-COVID complication, and that is not what the exact meaning which one try to decipher from the term long COVID. We will come to various definitions trying to address this disparity. So the not only this infectious complication, but also other vascular complication like MI or thromboembolic events or stroke. So these are all coming under post-COVID complications. In the first scenario, which is my case, I just had a complication of the cough, not even anything to relate, nothing to do with COVID per se. And in the second scenario, which is before COVID, the energy level was high. Post COVID, there was some fatigue creeping in during the later part of the day. So that is resonating. That scenario is resonating more with long COVID. Just to give you a perspective, I have explained this particular thing. So let's see how the various bodies have tried to put forth the concept of long COVID. How did the CDC define the whole thing? So CDC is saying the following: although most people with COVID-19 get better within weeks of illness, some people experience post-COVID conditions. So they use this particular term called post-COVID conditions for the same long COVID which we were discussing up till now, are a wide range of new, returning or ongoing health problems people can experience 4 or more weeks after first being infected with the virus that causes COVID-19. So they were not very particularly categorical that it has to be the same symptom or anything. It could be new symptom, returning of the old symptom, or ongoing health problem. And the duration they have capped as 4 or more weeks. So that is the CDC definition. So we all are, most of the time we are not just satisfied with Harrison. Usually we will, for whatever reason, we will go to Davidson as well. So CDC, as we know, it's a US guideline. So let us see what UK has to say. Nice definition. So signs and symptoms that develop during or after an infection consistent with COVID-19 and which continue to be there for more than 12 weeks and are not explained by an alternative diagnosis. So that is how the nice definition put forth the long COVID. So this is one interesting classification which I have came across. This classification is put forth by one Malayali colleague, the Ravindran et al. So in which he classified, this is published in Diabetes and Metabolic Syndrome journal. So in which within 3 weeks of onset of symptoms, it is the symptoms, if it is just persisting for that period, it is named as short COVID, and if it is more than 4 weeks, then it is past acute COVID. So it is termed as post acute COVID, and if the symptoms is lasting more than 3 weeks, then it is known as chronic COVID. And they have classified the post acute COVID and chronic COVID as the long COVID. Since this is an interesting way of looking at the post long COVID or post COVID condition, I just put this particular representation as well. So, but as we all know, finally we will have to, being a lower middle income country, we don't have our CDC or NICE to tell us what long COVID is. So we will eventually fall back to the WHO definition. So let us see how WHO wants to define the long COVID. So WHO came up with clinical case definition of post-COVID-19 condition pretty late, in 6 October 2021, just few months back only they came up with the definition. And we all know that from the beginning of this pandemic itself, WHO was always late. By the time the WHO declared pandemic, the world, everyone knew that it's a pandemic, and actually it was a pandemic square. So again WHO came pretty late into the picture with their own post-COVID-19 condition classification, and they come up with this classification based on a Delphi consensus, which is a survey model. They will survey the experts, and based upon the opinion of the experts from various fields, the public health, the clinical, and even the patients who can give good inputs, who have suffered the long COVID. So even their perspective has been included. So and this is the definition the WHO put forth. Post-COVID-19 condition occurs in individual with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, and other symptoms are also there, which have an impact on everyday functioning. Symptoms may be new onset following initial recovery from an acute COVID-19 episode. or persist from the initial illness. Symptoms may also fluctuate or relapse over time. A separate definition may be applicable for children. So this is what their broad definition of post-COVID-19 condition. So like in order to reach this consensus, this is how these are the domains they have tried to put forth to the experts who participated in the survey, and the consensus was put forth as the definition. The domain one is history of SARS-CoV-2 infection. So history of SARS-CoV-2 infection is a must, but then the SARS-CoV-2 lab confirmation was not a must. Minimum time period from onset of symptoms, 3 months was the time period put forth by majority of the experts. Minimum duration of symptoms at least 2 months. That is what the agreement was. Symptoms or impairments, cognitive dysfunction, fatigue, shortness of breath, all those things was agreed upon. Minimum number of symptoms, there was no consensus in the minimum number of symptoms. So even if a particular individual just have shortness of breath, still then it can be a post-COVID-19 condition. So clustering of symptoms is not a must. Time course and nature of symptom, like we already told, it could be fluctuating, it increase, it could be new consistent, persistent, relapsing. So all these things were inclusive in the definition. So all these things were fine. Sequelae of well-described complications of COVID-19 like stroke, heart attack. In our earlier case scenario, we told aspergillosis like infections. So all these were an exclusion criteria for long COVID, for post-COVID-19 condition. Symptoms cannot be explained by an alternative diagnosis. That was very important. If any particular, for example, I have shortness of breath, or an individual post-COVID has shortness of breath, and if found to have pulmonary thromboembolic complication, then it cannot be fit into a long COVID. So application of a definition to different population like children. So the consensus was the definition which they put forth is currently not applicable to children, and impact on everyday functioning has to be there. So these are the domains which they have examined, and then finally they reached to this conclusion and the definition which we have already narrated. So now, why we need a definition? Why are we spending so much time on trying to understand the definition? Because for recognition of the condition called long COVID, it's very important. We know that the incidence rate is 10 to 20% among the COVID recovered patient. When the world is going through a pandemic, if 10 to 20% of the population is going to have long COVID, then better we need to have a clarity. Why we need the clarity? For recognizing the condition, which will eventually help to provide better care, and measuring the burden of illness is very important, which also will aid and promote research as well as policy decisions to deal with these kind of post-COVID complications. So Dr. Al Ali, so he is one person who published in Lancet and a data of more than 2 lakh COVID patients. So let us skip the first portion. Second portion we will see. This definition is his opinion regarding the WHO case definition. So this definition is too little, too late. So I was hoping that the WHO definition would be more comprehensive and more inclusive. It does not move field forward a single inch. So what I was trying to put forth is that the experts are not really agreeing with the WHO definitions, basically because like it failed to taken into account other aspects of the long COVID, including the lab abnormalities. It's mainly constrained itself to the symptoms and then exclusion criteria, whereas the post-COVID organ system involvement can persist for a period, and there could be an objective way of assessing the same, which has not been included in the WHO criteria. So that is why many of the experts are not really very much enthusiastic about the WHO's definition. But that being said, as I told, we need a definition to put forth, and WHO is also very open about it. They are saying that as more evidence emerges, they will incorporate those aspects into the current definition, and it will become a much more comprehensive and encompassing definition. So is this always the case with the definition? What is the historical perspective on definition? So from a historical perspective, it took years to define AIDS HIV. With the first human immunodeficiency virus cases identified in June 1981 and the naming of AIDS in September 1982. The WHO AIDS surveillance case definition came only in October 1985. And again, there are recent examples like chronic fatigue syndromes. So WHO is always late to the party, and as far as definitions are concerned, there always has to have debate. And once we go through the definition, we will get a clearer idea, better idea about the condition which we are dealing with. So the common clinical symptoms which I already told, that it is the fatigue, shortness of breath, cognitive dysfunction, and any symptoms which impact everyday functioning. So, but these are the common clinical symptoms of long COVID. Symptoms may be new onset following initial recovery from an acute COVID-19 episode or persist from the initial illness. Symptoms may also fluctuate or relapse over time. So all these are permissible for long COVID or post-COVID-19 condition. Extended clinical symptoms. So other than the fatigue, other symptoms other than the fatigue, shortness of breath, and cognitive dysfunction which you were told, there could be persistent cough, joint pain, chest pain, memory, concentration disturbances, sleep problems, muscle pain or headache, fast or pounding heartbeat, that is tachycardia, loss of smell or taste, depression, anxiety, persistent fever, dizziness on getting up, worsened symptoms after physical or mental activity. So, like what I was trying to say, we need not remember all these things, but we need to have an understanding that the patient can present with lot of morbid symptoms which is affecting different organ systems. Sometimes they will present with a cluster of symptoms pertaining to one organ system. For example, cardiorespiratory cluster will be there, where the patient will be mainly presenting with shortness of breath, or while sleeping, they will have breathlessness. While getting up, they will have dizziness. So these kind of symptoms, or they can have gastrointestinal clusters, where the patient will have nausea or GI disturbances like constipation, diarrhea. So these things could persist for a period of time. And sometimes the patient can have musculoskeletal clusters, where the predominant symptom will be arthralgia, myalgia. So we should be aware that a patient post-COVID can come to us while sitting in OPD. A patient post-COVID can come to us with any of these symptoms pertaining to the organ systems, and then we need to have that idea. Okay, this could be a organ system symptoms clustering in the patient. So the clinical research. So this is the article which published in Lancet. So here what they have depicted is that with the passage of time, the COVID symptom severity kind of persisted, and the initial severity of the disease. So you can see, the bottom green line is the very mild, blue is mild, and the violet is the moderate. So as the severity worsened, then the proportion of patients who had a long COVID also worsened. So that is one thing which is depicted in, but then a very severe disease didn't really follow that pattern. But generally, as the symptom worsens to a certain degree, as the severity of the initial acute COVID, if high, the persistence of the symptoms are likely to be high, even though at the extremes that didn't follow suit. So again, like this data is again of more than 2 lakh individuals, out of which who complained post-COVID, majority complained fatigue only, followed by post-exertional myalgia, followed by elevated temperature, chills, flushing, sweats, skin sensation like paresthesia, numbness, weakness. So all these symptoms were kind of very common. So this is the figure from our study. So we did a study among 120 hospitalized individuals and 120 unvaccinated hospitalized individuals. So this study we did almost the early part of 2021. So what we understood is that in unvaccinated hospitalized individuals, up till like we followed up only for 6-week period. 2 follow-up was done, one in the 2nd week and second is in the 6th week. So out of which 70% of the individuals had fatigue. So just like the other study, majority of them complained of fatigue, followed by dyspnea, so shortness of breath, and shortness of breath persisted in 20% of the individuals up till a period of 6 weeks, which is kind of just adding up to the literature that 10 to 20% of the individuals can have post-COVID symptoms, which include fatigue, dyspnea. And the other interesting observation which we found is weight loss. We are not very sure whether it is due to the variant or whether it is due to the hospitalization, but weight loss was also a significant finding we observed in our finding, including loss of appetite. So a patient coming to you post-COVID, we need to ask for these constitutional symptoms like weight loss, loss of appetite, sleep disturbances. So other than usually they will complain of arthralgia, myalgia, dyspnea, fatigue and all, but then if you could proactively ask about these constitutional symptoms, then including the psychosocial symptoms, there is a scope for medication with which he could improve his day-to-day performance. So what is the pathophysiology of long COVID? Why an individual is developing long COVID? One, definitely is due to the virus itself. The virus has cytopathic effect, and second is the inflammations. So virus can induce the inflammation of the body, resulting in activation of various cytokines. These altered immune status along with the cytokine milieu can affect the organ system, and the organ system effect of the organ system can persist for a prolonged period of time. Along with that, also the other factors such as hospitalizations and drugs may also play a role for the long COVID. For example, in our study, we found an independent association of steroid with long COVID, and that in association of steroid was not really associated with the severity of the disease. So sometimes the drugs can also add on to the long COVID. So this is something we need to keep in mind. What about the risk factors? One thing we need to remember is that irrespective of the initial severity, long COVID or post-COVID-19 condition can persist, but still with increasing severity, there is a trend to have more persistent post-COVID-19 conditions, and it is twice common in women, increasing with age, but there is a preponderance for middle age, more symptoms in acute stage. That means if an individual had more number of symptoms during his initial days of COVID, then he is more likely to have a post-COVID-19 condition. And the presence of comorbidities. If you are otherwise healthy without comorbidities, the chance of you recovering is better. So this is an approach to a patient, but then we need not take the short COVID arm. We will just stick on to the long COVID arm after acute stage of illness if a person presenting to you with symptoms. So this is not really the approach of a post-COVID-19 condition, but post-COVID, if a patient presenting to you, then you can classify it into old symptom or new symptom. If it is an old symptom like arthralgia, myalgia, breathlessness, whatever he had, if he is finding that is not really improving, then definitely before labeling it as a post-COVID-19 condition, we always need to remember that this is a diagnosis of exclusion. So we need to exclude certain things. So what are the things which you want to exclude? So definitely we would like to exclude all secondary bacterial infection. We know that COVID as well as the treatment of the COVID, including the steroid, can predispose to various secondary infections. So COVID-associated pulmonary aspergillosis or COVID-associated secondary bacterial infections, we need to rule out. So that is very important. Then if if a patient presenting to you with features of leukopenia, thrombocytopenia, those kind of things, then definitely we are seeing a lot of post-COVID hemophagocytic syndrome. So if there are features suggestive of inflammation, so that also we need to during our OP visits, so look up for the markers of inflammation. If there are markers of inflammation, and maybe you can try some anti-inflammatory to see how the patient is responding to the post-COVID-19 condition. Now coming to the new symptoms, if a patient presenting to you with a new symptom, then we have to always see whether it is a complication related to his comorbidities such as MI or stroke, or it could be a complication related to the treatment per se. For example, as I told, due to the overuse of steroids in the scenario, the patient can have complication related to treatment as well. So this is the broader approach to a patient when you are sitting in the OPD. So diagnosis, as I told, it's all based upon the definition. So you have to exclude other condition, and as far as WHO is concerned, we need to follow up the patient for a period of 3 months, out of which 2 months the patient need to have symptoms. So at present, the diagnosis is mainly related to the symptoms. But then again, in this Lancet study, so and as far as we clinicians are concerned, we need to have more holistic view. We cannot just of course we can label a person as post-COVID-19 condition once they are fitting into the definition, but then once we are sitting in the OPD, we need to have a more holistic approach. And then the figure looks a little complicated, but the outer ring is the control and the inner ring is the cases, and the more brighter the color, it indicates the more number of abnormalities which they are seeing in the patient with post-COVID-19. So here the post-COVID recovered patients, lab data is what they are they try to interpret. So you can see there is leukopenia, there is dyslipidemia, there is hypokalemia, hypernatremia, and as well as there is hypocalcemia, and there is a HbA1c elevation. So the diabetes status also got uncontrolled. So there is this picture is actually trying to say to us that there is a lot of lab abnormalities, including the transaminitis and renal abnormalities. Along with it, there are metabolic abnormalities and there are electrolyte abnormalities, which are seen more commonly with post-COVID-19 patients. So the lab values, though it has not been taken into account in the WHO classification, as far as a clinician is concerned, we need to take into account all these lab parameters, and we need to do a comprehensive workup of a patient with post-COVID-19 condition. And of course, this electrolyte imbalances and the diabetic status, all those things we can definitely control. So that also we need to take into account. So what about the long COVID and vaccines? Will vaccine reduce the possibility of a long COVID? So the largest study, when I looked through the literature, the largest study I could find is the UK study. They looked at data of more than 1.2 million vaccinated people, and it found that fully vaccinated people had gotten both doses of COVID-19 vaccines, like those made by Pfizer-BioNTech, that is a mRNA vaccine, and Oxford AstraZeneca, that is our equivalent to our Covishield vaccine, had almost 50% lower odds of having COVID symptoms at least 28 days after infection, which is kind of very promising because the vaccination is going on at a higher pace. So that will hopefully reduce the burden of the long COVID further. Now coming to the management. So the unfortunate fact is that we don't have any particular treatment per se for long COVID. But as I told, the symptoms we can address, probably the constitutional symptoms, the sleep disturbances or the anxiety, those things we can address. The lab abnormalities and the metabolic derangements, those things we can address. Other than that, we need to listen to the patient, and then we can give this general instruction tailored to the individual patient. Understand when you have the most energy, plan how you want to use it and pace yourself. Don't overdo it. So refer to the scenario of scenario 2 of my colleague, which I have narrated in the initial part of the talk, and break the tasks to small groups. Don't stop doing things that make you breathless, but take it slow. Exercise when you can. Start light and build the intensity. To ease muscle or joint pain, try low intensity, flexible exercises like yoga or light stretches. Know that some days may be worse than others, so that you need to accept it. You cannot just go on with same intensity on all the days, because the long COVID has the relapsing remitting nature. Living with symptoms like brain fog, breathlessness or chest and joint pain on a daily basis can take a toll on mental health too. Chest physiotherapy and neuro rehabilitation is important in patients with pulmonary and neuromuscular sequelae. Optimization of the worsening comorbidities. Those with severe symptoms and progressive worsening need frequent in-person review. So these are the general instructions which we can give, and then you do a comprehensive review and tailor the treatment individually. So what I tried to tell is that a tsunami of disability is coming as a result of long COVID. So let's prepare for that. And thank you, one and all.
Thank you, Dipu sir, for that wonderful presentation on long COVID. Actually, we have a few questions, sir, about this long COVID. I think because of we are running short of time, we'll just cover a few of those questions. Someone has asked whether can recurrent COVID infection fit into post-COVID? Can a recurrent COVID infection be called as post-COVID?
No, post COVID-19 condition is, like you need to have a history of COVID-19. That's it. You cannot have recurrent episodes of COVID-19.
Okay, then someone had asked about an initial aspergillus endocarditis. Did it occur after the patient tested negative for COVID-19? And was there any lab evidence for immunocompromise at the time? In the patient who developed aspergillus endocarditis?
Yeah. I understood the question. So that's very interesting question. So the patient came to us 1 month after recovery. So the patient was in the hospital for a period of roughly 3 to 4 weeks, then got discharged, was in the house for a period of 1 month, and then the patient developed a blurring of vision, because of which they went to another hospital, and then they referred the patient over here. When the patient reached here, like there was no definite evidence of any immunocompromised status, but from the history we know that the patient had COVID-19 and had a history of steroid intake.
Okay. Then one more question was: is post-COVID a symptom-based diagnosis? Are there any relevant investigations to diagnose post-COVID like that?
I think I already addressed it. As far as the WHO is concerned, right now it is a symptom-based diagnosis, but we need to exclude other causes for the symptom, for the development of that particular symptom. For example, as I told, shortness of breath can be due to a thromboembolic complication. So we need to rule out that. So even though lab diagnosis, they have not, WHO has not incorporated, since they have put this word that it is an exclusion criteria, it is up to us to do the basic lab work and to tell that there is no objective evidence for the symptom which the particular individual is having.
Okay, and someone has asked about new onset diabetes after COVID. Does it come under long COVID or post COVID?
As far as definition is concerned, it cannot be, because diabetes is a, how will you diagnose diabetes? You diagnose diabetes if HbA1c is more than 6.5 or FBS more than 126, and the PPBS criteria. So it is a lab-based definition. So right now, I agree. I appreciate the fact that he is understanding that who has asked the question is understanding the fact that there are lot of new onset diabetes we are seeing after COVID.
The one more question was, once somebody acquires COVID-19, like how long is the person at risk for organ system complications? I don't think it's exactly related to the present topic.
So towards the end, I have shown that Lancet, in which they have examined almost like more than 2 lakh individuals. So in which the common association post-COVID they have found is lot of electrolyte abnormalities, hypokalemia, hyperkalemia, hyponatremia, hypocalcemia, and then there is transaminitis and blood urea elevation, not creatinine elevation, but still they have observed that, as well as then metabolic abnormalities like dyslipidemia and loss of diabetes control. So this is what when they looked at 2 lakh data, this is what they have very commonly observed.
Okay, another question was, if somebody is having post-COVID respiratory symptoms, day 8 after acquiring COVID, can they still be transmitting COVID? Day 8.
Yeah, right now I understood where that question is coming from, because right now the government has reduced the quarantine to 7 days, but theoretically they still can transmit COVID, but with each passing day the chance of transmitting COVID will come down. And I would like to clarify one more point: the 7-day classical quarantine period is not for somebody who is still sick and still hospitalized. So they can theoretically still transmit COVID, though practically the chances are very, very less likely, unless you are doing an aerosol generating procedure like tracheostomy or suctioning of the secretions.
One last question was, is it worth further classifying long COVID into a post-acute COVID versus a chronic post-COVID, where post-acute COVID is symptoms persisting 4 or more weeks and chronic post-COVID persisting 12 or more weeks after? Is it worth classifying that like that?
Like all those are various classifications. I think that question is coming from the Ravindran et al.'s data.
Okay.
So basically, at that point of time, he has proposed that in 2020 he has proposed, and by mid 2021 this got published. So he has proposed it pretty early in the disease. So as the data evolves, I think we should be more inclusive. So we need to have that comprehensive idea that the symptoms could persist for a prolonged period of time, and there are agents like CDC who told that even after 4 weeks, if they have persistent symptom, we have to classify it as a long COVID or post COVID-19 condition. So that is still a gray area, but as far as practice is concerned, we should able to give some kind of meaning into it, whereby we can say that the post COVID-19, even though the WHO case definition, even though they are not really fitting into the WHO definition of post COVID-19 condition, still they have some kind of post COVID-19 scenario. So I still feel that there is a role. Yeah, my single answer is yes.
One more thing, like now we are going to this Omicron surge, no? So Omicron and long COVID, anything?
Yeah, actually, I would like to say that it is too short a period to comment about Omicron and long COVID, because long COVID is long and Omicron is just now hit.
Okay. Okay. And anybody who got Regeneron monoclonal antibodies, now it's being used right and left. So are they coming back with long COVID symptoms?
That is a very interesting question. I think whoever asked that question, I thank them immensely. This we will definitely consider it as our next project, and we'll get back to you.
Okay. 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 Thank you, Dipu sir. Thank you. Thank you for the wonderful presentation.
Okay.
We'll go on to the next talk. We are already running a little behind schedule. Thank you. Thank you.
Okay, bye.
Thank you, sir, for that very informative session. I'm sure that has clarified a lot of doubts that we've been having about COVID and post-COVID.